Adjunct Associate Professor of Internal Medicine, Texas A&M Health Sciences Center, School of Medicine. So welcome to the stage, Dr. Weldon.
Thank you. Since this is being recorded, I won't be making any politically incorrect jokes. So I want to thank the ASAP board and Bob Lanier for the invitation to come speak to you today. So this is going to be a whirlwind. How many physicians do we have in the audience? Okay. PAs, physician assistants, nurse practitioners. Okay. So pretty much distributed. So these are my disclosures, and I just want to say that with the exception of antihistamines, corticosteroids, and omalizumab, most of what will be talked about will be off-label, okay? And so basically what we want to do is talk about making the correct diagnosis, pathophysiology behind etiologies, appropriate laboratory testing, as well as future treatments for urticaria and angioedema coming down the pipeline. So a few examples here of urticaria or urticaria-like presentations. This lady presented with hives, lasted for a while, and the hives were pruritic, did not respond with antihistamine. So is that true urticaria or not? This guy presented with tender hives, and the hives refused to respond with antihistamines, and they did leave residual pigmentation. Is that a urticaria or not? This lady had pruritic hives involving only her lower extremities. Again, unresponsive to high-dose antihistamines. Is that an example of urticaria? And then this young lady came to me with a history of lower lip swelling ongoing for the previous 7 years. And she would respond with oral prednisone. She thought that she had a food allergy. Is this an example of angioedema? So what you think about this, we'll go over them at the end of the discussion. Anyway, getting terminology correct, urticaria is always itchy and it always has a wheal. Okay, you should be able to palpate it. It's not a rash, so to speak, okay? The wheals may blanch when you apply pressure to them, and they may look like they have a central clearing, but that's because of the underlying pressure. And generally, they're widespread. They're not, with the exception of contact urticaria, they're not just localized. Angioedema, if it's histaminergic, in other words, histamine mediated, it'll itch. But otherwise, it's mostly painful, burning, stinging, and that may indicate a different mechanism called bradykinin mediated. With the histaminergic type, they may be quick in onset and relatively slow in resolving, whereas with bradykinin, it's always slow in onset and slow in resolution. So when you think about the types of urticaria that are out there, there's the acute variety and then there's chronic. And pretty much the dividing line is 6 weeks. Anything longer than 6 weeks is deemed chronic. With the acute urticaria, that's the most common, fortunately, and usually it's like stinging insect allergy, medication allergy, especially non-steroidal anti-inflammatory agents, antibiotics, contact allergy, like if you have a child that has a cat allergy and the cat licks them and they develop hives on their face. Mast cell activation is a new terminology, and it can be associated with either flushing and or urticaria, and certainly anaphylaxis can be urticaria, and fortunately it's acute. Whereas chronic are going to be a little bit more involved. They usually will resolve within 1 year, but with notable exceptions, and the exceptions are some of the more common inducible forms. Autoallergy plays a critical role in the chronic urticaria compared to the autoimmune, but it's the autoimmune urticarias that give us the greatest fits, okay? And cancers, fortunately, are extremely rare. This is an example of inducible urticaria dermographism. It's the easiest thing to define. You just take a tongue depressor, stroke their back, and they'll hive up. And then you take a picture of it and show it to them. So this is what's besieging you, okay? And usually this responds with high-dose antihistamines. Cholinergic urticaria usually will, these fine little small papules that urticate come up with an increase in the body temperature. So if they exercise to sweating, take a hot shower bath, and this one also is very susceptible to emotions such as anger and stress. The majority of these two inducible urticarias are the ones that I see in my practice, and they're also oftentimes seen together, okay? And if you treat one, you get the other. And then cold-induced urticaria, this is what is called a cold stimulation tolerance test. Put a bag of ice on their forearm for 5 minutes. Don't forget to take it off in 5 minutes, okay? Otherwise, you're going to have an unhappy patient. But in any event, as the skin warms, then they develop this wheal, and you can see formation of a wheal. And if you can't, just imagine, okay? So types of urticarias. We have type 1 chronic spontaneous urticaria, which is IgE mediated, okay? So this is new terminology, and I'm sorry, but I had a senior moment and didn't put the accurate reference to that, but it's in the JACI in practice. But in any event, it's an IgE-mediated process to endogenous autoantigens, especially to thyroid peroxidase or interleukin-24, okay? Now, this is where we have need for accurate testing, because we don't. This is mostly research at this time, and they publish these papers and they go, ooh, that's really cool. Where can I order up that lab test? Well, you can't. 5 years later, you still can't. 10 years later, you still can't, okay? So it's a common need that we all have in giving the patient an accurate diagnosis. But in this, because it is IgE mediated, you get a more likely response to antihistamines as well as to omalizumab. Whereas type 2B chronic spontaneous urticaria, this is a little bit of a difference in the Jelen-Coombs. How many of y'all remember that? Okay, well, yeah, like me, most folks will forget Jelen-Coombs as soon as you exit the lecture hall in medical school. But the thing about it is that there's a type 2A, which is cytotoxic antibody. All right, so this is the response that destroys red blood cells with an antibody. This is type 2B, which actually activates cells, okay? So it's not destructive, it just activates the immune cells to misbehave. And these are mostly antibodies, M, G, and A. The majority of these folks are ladies, and they have, as you might envision, a high inflammatory process that's not IgE mediated. So diagnostics will reflect that. So they may have a spontaneous, they have autoimmune skin test reactivity, where you take the blood, spin it down, and then you inject it back in intradermally into their skin, and they hive up. They have basophil activation test, basophil histamine response, and you can measure this, the IgG anti-high affinity receptor on the mast cells. But invariably they have poor antihistamine response and poor omalizumab response. So these are the ones that vex us and give us the most grief. So you can see by this diagram here that it's more than just IgE mediated. So the top here would be all of those that would have some relationship either to IgE or the IgE high affinity receptor on the mast cell. And the mast cell is your source for all things itchy in these patients, okay? And then below, then you have a whole host of autoimmune type of processes. And those include things like MRG PRX2, which is originally received attention because of medications stimulating that particular receptor. That's your fluoroquinolones, some of your neuromuscular blockers, opioids will stimulate that, but also, more important, is substance P. Okay, substance P, as you'll probably hear in a lecture on itch, is a pivotal itch provoker in patients, okay? And it also then will stimulate the release of mast cells as a result of activation of that. We know that pathogen with activation markers and the microRNAs have received a lot more detail as a result of COVID, and as well as COVID vaccinations inducing urticarias in patients. Complement C5a receptor sits on the surface of the mast cell and will promote, when activated, provoke release of the mast cell granules. And so when mast cell releases their granules, it's an all or nothing type of phenomena. So it's not something that's leaky. It's there, and everything that's in the preformed granules get released, as well as prostaglandins that are then produced on the cell surface of the mast cells. And then we have alarmins, which will come into play later when we talk about new medications that might be of interest in therapy for our patients. And then at the very end here is thrombin, which when you have activation of your coagulation cascade, thrombin may stimulate in high amounts the activation of mast cells. And this is an association with urticaria and angioedema. This article is straight out of press, and so it's to be published in the JACI in practice. It's a great article. If there's one article you need to read, it's this one, okay? And it pretty much establishes a relationship between some of the uncommon players that occur with chronic spontaneous urticaria. And I want to draw attention specifically to the tryptase group, alpha and beta, in which you can have, in addition to release of the histamine, you have tryptase that is released, and tryptase serves for us as a marker for anaphylaxis. But in some patients who have alpha hypertryptosemia, they also will present with urticaria. And there is a familial form of vibratory angioedema that occurs more in those patients with the hyper-alpha tryptosemia. And then we have sulfated compounds that come in here, and sulfate heparin, and an abnormality of that is associated with hereditary angioedema. And then this is the kallikrein-kinin cascade that we're going to talk about a little bit later as far as forms of hereditary angioedema, and especially hereditary angioedema with normal C1 inhibitor. And that's going to be in a later lecture if you're still awake by then. So this is an article that pretty much splits the histaminergic versus non-histaminergic. The thing to focus about with the histaminergic is it's usually associated with urticaria, okay? Whereas non-histaminergic is never associated with urticaria, okay? That doesn't mean that it may not happen, because you could have two different processes causing it. But the non-histaminergic is usually bradykinin mediated. And bradykinin, as I said, is a lot more difficult to treat and serves as a reason why patients don't get better with our standard therapies of antihistamines, corticosteroids, and epinephrine, okay? So we'll come back to that little haunting graph a little bit later in the lecture on angioedema. So what's not urticaria? Okay, that which burns or stings is not urticaria. So reflect back on that second slide. All right, it leaves a mark. Second slide. Blistering is not urticarial. Perhaps the third slide, you didn't see that. It can blanch, but if it's central fading, it's not. Target lesions are not. Okay, erythema multiforme is not. Rashes with scale. In other words, if it's flakes, that's not urticaria. It's more of a contact dermatitis or a fungus among us. Okay, and again, target lesions may be more erythema multiforme, or it could be a sign of Lyme disease. Other things that can be mistaken as urticaria and angioedema, certainly flushing. I see that all the time. They get referred to me for urticaria. It's not urticaria. Lichenoid drug eruptions. Drug eruptions can do whatever they want. Okay, they can present as urticaria, but more likely they present as something else. All right, and knowing the differential diagnoses of that is another lecture that's best given by Dave Kahn. Anyway, what is angioedema? Angioedema is going to go away within a defined period of time, okay? Usually, if it's histaminergic, it's going to go away within a day or two. It's not going to be prolonged angioedema, and certainly if you reflect back on that young lady who had swelling of her lower lip for years and years, that wasn't angioedema, okay? That was something totally different. And again, angioedema, with the exception of that which is bradykinin mediated, is usually associated with urticaria, okay? About 10% of people who have urticaria and angioedema actually have just angioedema alone. About 50% have urticaria and angioedema as a presentation, and about 40% will have urticaria alone. Okay, so that's the lay of the land, and mostly those are in your acute phases. Differential diagnosis for angioedema includes a wide variety of things. Thyroid orbitopathy is one. I keep pressing the wrong button there. Thyroid orbitopathy, where they'll have swelling of the upper eyelids, especially in a lady that might be postpartum. So think of that as far as autoimmune thyroid disease provoking the swelling. Michelson-Rosenthal syndrome, that lady could have been Michelson-Rosenthal, but as you'll see, that wasn't the case. And then Gleich syndrome. Gleich syndrome is associated with high peripheral eosinophilia on the CBC, is associated with sporadic angioedema. Okay, so it is not angioedema per se. So what type of test are you going to order, doctor? Well, you know, are these going to be helpful for us anymore? No. None of these are really going to be helpful, okay, unless your history and physical examination might infer something. So if you've got somebody that's having weight loss and having polyuria, then you might get a CMP or, to define diabetes. But otherwise, those type of things, whereas used to be thoughtful, are no help, okay? So what may be beneficial for us? Well, this is the new thought, okay? CBC to determine eosinophils and basophils, okay? Thyroid peroxidase, currently we only have an IgG specific for thyroid peroxidase, but that's going to be a helpful marker of an autoimmune condition, okay? So that leads you more to that autoimmunity-derived type of urticaria, and at high levels, it correlates with IgE-specific thyroid peroxidase, okay? But that's the one that we can't measure, and that's the one that we really need. An Alcolicus serum skin test, well, unless you have a centrifuge in your office, forget that one, okay? Total IgE level, as well as a D-dimer. Those are, you know, the CBC, the thyroid peroxidase, the IgE, and the D-dimer, that's easy to get. The rest of this stuff is send-outs, okay? And so, you know, if you're going to get a quick answer for your patients, those are the things to get, especially when they have chronic urticaria for which nothing seems to be working for. And those all with the exception of the total IgE, tend to be more helpful for you with your chronic autoimmune urticarias, okay, at defining who may respond with antihistamines and who may respond or not respond, as the case may be, with omalizumab. This is an autologous serum skin test where you get swelling at the site of the injection. And then basophil histamine reactors due to stimulation. The higher the level that the patient may have basophil histamine receptor activation, the more likely they have that autoimmune type of urticaria for which they're going to have a poor response to things like omalizumab as well as antihistamines. So how should we treat it? Well, you start simple. Basically, the majority of people probably have tried Benadryl, and so they come to your office or to another provider's office, and they're itching to see you, needless to say. So you just double up on the amount, even quadruple amount, okay? That's no biggie. If they have oropharyngeal edema, that would be my indication for the use of oral corticosteroids. But otherwise, I tend to refrain from trying to use oral corticosteroids, at least in the acute phase. But the problem with the acute phase is sometimes when the urticaria is really, really tough to treat in that acute phase, it's going to be tough to treat for that period of 6 weeks, okay? And you may wind up, for the patient comfort, in putting them on oral corticosteroids. And in my opinion, the risk for osteonecrosis of major joints is overstated, okay? It's very rare, okay? And I can base that on an article I published on osteonecrosis way back, I forgot when. So this is some of the information regarding what is antihistamine responsive and non-responsive. If you look at all this here, these patients have a lot worse basophils, in other words, minimal. They have larger platelets. Their C-reactive protein is significantly elevated. And so those are some of the indicators to tell you that maybe they're not going to respond with the antihistamines, and to delay on further therapy is only going to make the patient mad. So when we look at antihistamine use in chronic spontaneous urticaria, some of the things that will tell you, again, that you're going to have resistance to the antihistamine is that D-dimer, okay, or elevated CRP. Those are things that are going to tell you, well, you know, we could try this, very high dose, but we may be looking to advance a little bit faster for your therapy. And then again, this is in chronic spontaneous urticaria after the patient's been on these medications for greater than 6 weeks. All right, there is no significant risk in quadrupling the dose as far as cardiac goes with the second generation antihistamines. Okay, that's the good news. However, with the first generation antihistamines like diphenhydramine, you can have problems with prolongation of QT syndrome. And the other thing about it is that when you look at more mature folks like me and Bobby, okay, you know, these folks over a period of many years, the more of the first generation antihistamines that they take that have this anticholinergic side effect, the more likely they may become demented or have Alzheimer's, okay? So, you know, these are some of the, a listing of the anticholinergic antihistamines. The favorite to use with urticaria is doxepin, okay, because it has very potent H1 and H2 antihistamine activity. But again, you get into fall risk when you're looking at these anticholinergic antihistamines, and in the more mature population, if they fall, they break something. And so nobody's going to be happy about that. So this is kind of a summary of where we are based upon the EACI recommendations. That if it doesn't respond with 4 times the second generation antihistamines, then you jump to omalizumab, and you really want to use omalizumab for about 6 months if possible. And if that doesn't work, then you go to cyclosporin, okay? And again, this cyclosporin would be off-label. In using omalizumab, you want to choose patients that have an elevated IgE level, okay? Those with very low IgE levels, they're not going to respond because that tells you it's not an IgE-mediated process, okay? And so once control is obtained, then you can start ratcheting back. So at this time, omalizumab is indicated 300 milligrams subcutaneously every month, but you could extend it further, and insurers love for you to extend it because it costs them less, all right? But sometimes you may have to jack it up, and this will be an off-label indication here of using it every other week or even at 600 milligrams monthly. I can tell you I haven't had to go to that because usually if you're having to do that, it's not going to work. Okay, that's what I've seen in my experience. So again, this just kind of reminds you again. I know this is like beating a dead horse. Okay, is that what's inflammatory and with inflammatory markers is not going to respond with antihistamines and is not going to respond with omalizumab. So you start thinking ahead and advising the patient of the risk and benefits associated with certain types of alternative agents that are off-label. But this is a nice summary slide that shows both resistance as well as those who are likely to respond to antihistamines. And then with cyclosporin, again, this is an inflammatory process that these patients have, and they're more likely going to have a reflection of that inflammation with the elevated D-dimer, the elevated CRP, and if you do the ASTT or basophil histamine response that's elevated, they're going to have a better response. These patients also have low basophils and low eosinophils to begin with, okay? So that again kind of shifts you a little bit more towards that it's not an antibody E-mediated process, but more of that type 2B process with the antibody stimulating the mast cells to misbehave. And this is a listing regarding some of the off-label use of medications. Dave Kahn likes to use tacrolimus instead of cyclosporin for management because of less side effects. Sulfasalazine and hydroxychloroquine. Hydroxychloroquine, I've found that in patients on biopsy who have a lot of neutrophils, seems to work better. Alan Shockett commented on that long ago in the last millennium. And colchicine, I've only had one patient who's responded with that. And as you can see in these randomized controlled trials, it really didn't make a big difference. The same thing with methotrexate. So again, this is another summary slide for y'all to ponder. Again, it pretty much lines up, the things that tell you what is a non-IgE mediated type of urticaria versus what may be IgE mediated. And if it's IgE mediated, it's going to have a better possibility of responding with high-dose antihistamines as well as omalizumab. And if it's not, then you start to have to think out of the box. So what's in the pipeline? Bobby, how much time do I have left?
You're good.
Okay, all right. So this is a great slide here that is, as we call, busy, all right? But it describes some of the folks that we have available to us. To use them now would be off-label, all right? But this is what the forward thinking is, to attack some of these support cells that come in, especially eosinophils, in addressing that which are collaborators in the criminal activity of the mast cell in our patients with urticaria. And then these guys up here are those that are in the pipeline. Okay, how many of y'all have had your coffee? Okay, because this stuff is state of the art and very, very intense. But the purpose of this is kind of like that, AI type of future for us, and determining what may be the pathophysiology of urticaria versus what's less important. And what they did was they used a therapeutic performance mapping system technology and combined that with machine learning, there's your AI, as well as systems biology. And they came up with this, okay? Well, that looks like a dartboard, okay? And especially the way I throw darts. It doesn't have any sense to it. But when you take the individual clusters out, what you then find is that you have specific types of processes that lean more towards adaptive, innate mast cell activation, IgE signaling, as well as adhesion, motility. This is more like with the eosinophils, okay? And so the summary statement of this is that they looked at some of the future for us outside of omalizumab as to how we may be addressing chronic spontaneous urticaria in our future. And they found that anti-IgE, again, that would be your omalizumab and ligelizumab, and Bruton's tyrosine kinase inhibitors have the most probable relationship with mast cell activation, degranulation. And anti-cyclic 8, anti-IL-4, and anti-IL-5, okay, those are, the latter two are some of our friends out there that are of our pharma representatives that are available to us now. Same thing with the anti-IL-4 and IL-13 accesses as far as humoral mediators of inflammation and endothelial changes, and then and anti-IL-4 and IL-5. So why is this anti-IL-5 really important? It's eosinophil, okay? So the thing about it is that when you go and biopsy somebody, it's just, you don't see the mast cells, you see eosinophils and lymphocytes. So the eosinophils are actually the troublemakers outside of the histamine and the tryptase, okay? So they're responsible for all the damage. As I tell my patients who have asthma, they're kind of like sloppy janitors of the immune system, okay? All right, so this is the listing of the therapies that are that are in the works, okay? And some of those who are available now for us. Ligelizumab, when you look at all the comparison studies between it and omalizumab, really there was no superiority. Safety, yes, but as far as superior activity against chronic spontaneous urticaria, they were pretty much neck and neck. That's the reason why we haven't seen it, okay? Because it really didn't do anything for asthma. So I think that they pretty much canned this one. Dupilumab, okay, versus 4 times the antihistamine unresponsive chronic spontaneous urticaria does show benefit in those folks, okay, as you would expect. And it shows a lot of response with the eosinophil-mediated disease process also. So you can put chronic spontaneous urticaria in that eosinophil-mediated process as far as the inflammatory component. Benralizumab is by infusion. This is Jonathan Bernstein's article in which they showed improvement in the urticaria scores in patients who were on this after infusions over several doses. Okay, who comes up with these names? All right. You know, I might die of tongue aspiration trying to say these things. Okay? All right. Lirentelimab in chronic spontaneous urticaria. This is an anti-Siglic 8. All right? And so it showed very favorable responses in all patients, those who had been on omalizumab before and those who are naive to omalizumab. And then an anti-c-KIT. The c-KIT is the stimulatory drive for mast cell reproduction and survival. And as you can see, everything looks good, okay? All these things going downward point to less activation, and especially this guy right here with your less tryptase activation, okay? And then this is an anti-Bruton tyrosine kinase. That seems to be a theme that is coming forth in a lot of management of a lot of autoimmune disorders, is to put them on something like this. So, if it looks like a duck and quacks like a duck, ergo is a duck, okay? And so, how many of y'all biopsy in your practices? Okay, consider it. It's a lot of fun. You know, it is reimbursed by Medicare of all people, okay, or used to be. So looking at that lady, all right, she had urticaria for a long period of time. In other words, her hives would last for days and not hours or a day. And in biopsying her, yeah, it does look like urticaria, but what's the difference between that and something else? Well, there is this thing called a dermal hypersensitivity reaction. It looks identical to urticaria, it just lasts longer. But these dermal hypersensitivity reactions are refractory to antihistamines, okay? So it's more in that autoimmune character. Does it respond with omalizumab? Don't know. How about this guy? Stinging, leaving hyperpigmentation, biopsy, all right? He has this fibrinoid necrosis. In other words, the blood vessels are filled up with a bunch of junk and dying cells. They're plugging the blood vessels. And that is a cause for that hyperpigmentation in those patients, okay? Again, not IgE mediated. This is the urticarial phase of bullous pemphigoid. Oftentimes these patients will present with hives, and they may present with hives for several months before they start to blister up. But the unique thing about this is that it may be segmental, as in this lady who was down in her lower extremities. But when you biopsy it, you do not only your H&E, but you do an immunofluorescence, and you'll see this, this linear pattern of IgG specific for the basement membrane. And then this young lady sent her to ENT with the purpose of excluding Michelson-Rosenthal syndrome. It wasn't. What happened is, if you look up here, she has all these little holes here, or spongiform process. And what she had was a contact dermatitis. And by serendipity, I mean, she was insistent that she had a food allergy. Says, okay, I'll test you for a food allergy. Okay, didn't think it was a food allergy. Well, our patients are our best teachers, okay? We don't know, we don't have all the answers. Sure enough, her immediate skin test was negative. I was bringing her back based upon the based upon the biopsy, do patch testing, which came in. She had positive reactions to Saccharomyces, okay? Delayed type hypersensitivity to Saccharomyces. Okay, well, let's just take that out of your diet. It went away. 7 years of swelling went away by avoiding that. And that's in your flavoring agents. Whenever you have a bag of potato chips or something like that, it says flavoring agents, that's a yeast product, okay? Now, this is not Canada. This is Saccharomyces. This is beer, okay? I mean, root beer. You got to stay away from it. So she's a happy camper now. So in conclusions, common things are common, all right? Go with your antihistamines, high dose first. Doesn't work, move on to omalizumab. That doesn't work, then consider that it might be autoimmune. You can check autoimmune indicators, CRP, D-dimer, check your CBC. Low eosinophils, low basophils argue in favor that they're not going to respond well. And certainly if you have an IgE level that's very low, that's not going to respond well with omalizumab, okay? And until our alternative biologics are approved, you're going to have a hard time getting through insurers trying to get approval for some of these newer or current agents that are indicated for the management of asthma and trying to and use them for urticaria. But don't be surprised that that indication doesn't come forth pretty quickly within the next few years. Okay? And I thank y'all.
All right, we have a few minutes. Does anyone have any questions about Weldon?
Yes, sir.
Well, great talk. Thanks so much. I just kind of wanted a little clarity. When do you typically start sending labs? Do you put them on the high-dose antihistamines and see if they respond? If it's nice, or are you doing it right off the bat?
Well, the way things work in my clinic is pretty much the minute they go see somebody in urgent care or convenient care, they're automatically given a referral to me, okay? So within the week, I'm seeing them. So I put them on high-dose antihistamines unless something in their history and physical tells me otherwise. I mean, I found some thyroid cancers in my practice, okay? Has nothing to do with urticaria, all right? But if you do a thorough history and physical examination, you'll be surprised what you find. So pretty much, you know, I mean, although they downplay the importance of getting Helicobacter pylori testing, if a patient has gastritis and reflux symptoms, I'll usually check a stool. Don't bother checking serology, because you don't know when they may have acquired the H. pylori in the past, and it'll always be positive. But if you check a stool for the H. pylori antigen, it'll be positive. Now, the big question is that the chicken or the egg, okay? And most oftentimes I've found that it doesn't have any relationship with the urticaria, but it makes them happier because their gastritis is gone when it's treated appropriately. Yes, sir.
That was incredibly well put together, David. It's nice.
Thank you.
Now I'm going to be that guy.
Okay.
Always has a comment. Twice in the last 4 years, having treated someone with allergies and elevated IgE, and both of us becoming frustrated around the 8th month with a palpable but not good reaction to omalizumab. In desperation and great apology to the patient, I said, you know, sometimes an infection that you read about it and rarely ever see it. Both those patients had impacted sinuses. When they were treated, urticaria went away.
I agree.
I am not suggesting that you do CAT scans on everybody with urticaria.
Right. And you're absolutely right. I currently have a patient that I'm managing who is in that regards. The thing about it is it an example of acute, then chronic bacterial sinusitis, for which antibiotic intervention may be beneficial? Or is it a manifestation of chronic hyperplastic mucosal disease seen on the CT scan? And the difference probably will be the air fluid level, okay? And coupled with symptom scores, all right? And I think we have somebody that's going to lecture on that later on so they can clarify that. But absolutely, I've seen it with prostatitis. I've seen it, successful treatment of prostatitis. There goes the urticaria. So this is where that history and physical examination really is important. And I'm not advocating people have a routine digital exam in their H&Ps, but that's the reason why I have gloves in my office, in order to advise gentlemen, if you don't behave, Okay? Yes, ma'am.
It feels like to me I've seen so many more hive patients than I ever did pre-pandemic. Do you think there's a long haul COVID aspect to it? Any information on that?
I don't believe that there's a long haul COVID. I think that number one, if they had COVID and then urticaria and have continued to have their urticaria, maybe, but that's just not part of the long haul criteria for that. Certainly with vaccinations, you'll see that, but typically the patients who have COVID and urticaria will have that urticaria a couple of weeks after the COVID, especially in children. Okay, same thing for the vaccination. Patient gets vaccinated, 2 weeks later, they've got hives. Are they allergic to the vaccine? Probably not, okay? Again, it's probably that mRNA stimulating the mast cells to misbehave. And all of those urticarias, in my experience, have always been acute. They've never been chronic. Anybody else? Again, you got to put up with me a little bit later on after lunch, okay? So thank you all for your attention.